Your house of care rests on commissioning. From what you know, I'll start with Kathy, and then I'll come to you, Martin. From what we know of the Australian context, how realistic is that commissioning piece? If we were to emulate, we can see the other things around. Commissioning is the one piece that we might struggle with.
I'll make a comment, I think, to start about the tension that I think exists in New South Wales for the state-funded services at the moment between the ministry that thinks it's a purchaser and people at the LHDs that think that they're there to decide what their local population needs and who's best to do that. And I think that's a fundamental tension that needs to be resolved. So commissioning, for me, there's sort of to try and define some terms. Funding says I'm the person who's going to give you your share of the money, and I can do that based on population need or a quantum of activity I want you to deliver. That's not commissioning. Commissioning is that step further that says I want the care to look like this in this quantum for these sorts of people. We don't do commissioning in Australia.
Could we?
We do funding, but we call it commissioning or we call it purchasing. But I don't think we've got any real evidence. I can't point to anything. The NDIS is potentially the first example we will have of what I think is a commissioning model, and it's got a whole lot of problems already, not necessarily of its making.
Martin? So what you know, from sort of 10 minutes in Australia, we'll make you out that.
I think there's more similarities than differences. We all like to think we're different, we're unique, and we have a unique set of principles, and we create a huge number of assumptions to reinforce that perception. I think we've both got similar problems. I think there is a lack of understanding. I mean, one of my frustrations is that most people in the UK think that commissioning is contracting and procurement, and it isn't. It is a far more about understanding the needs. You know, where are we now? Where do we want to be? How are we going to get there? So you have to understand where you are now in terms of your population health needs, in terms of the service delivery, in terms of the quality of that service delivery. You then need to start building about, so what levers and tools do I have, incentives, contracts, but also stories to tell people about how do we make change happen, who owns it, what are the cultural barriers to this, and address those systematically. I think the problem is I'm now on my, since I went full-time into NHS, what I call system doctoring, I'm on my 4th organisation. So I've been reformed 4 times.
No. So let's go back to your Peter Drucker phrase, which is culture eats strategy for breakfast. Give me and everybody knows what you mean here, but in the context from where you come from, what's the culture that has to be changed and how? And grace and good favour, goodwill, incentives, stakes. What's the story?
So there's aspects of culture which need to be changed. So the first one is to change the nature of the conversation between professionals and people with enduring conditions, because the model we have at the moment, the culture we have at the model, is a 20th century model. And we need to understand how to mobilise carers and community assets, as well as the person themselves, as much as they want. So that's the first thing. I think the second thing is, and we've run into this quite hard in the last year, and I was very interested in your comment about the 7,000 people and sharing health information. When you have conversations with people in the UK, most of them assume, the GP's got a computer screen in front of them, and they're putting all the details on. They just naturally assume that will be available to the consultant in the hospital if they have to go to the hospital. They assume that, and it comes as a bit of a shock to them to discover that is not the case. And I think there's 2 things. One is there's about actually sharing information with individuals, because information is power. Therefore, the medical profession would like to keep the information to itself because that retains a power base. But the second thing is linking information across the system so that we can start to purposefully run what I would call population diagnostics, so that we can inform commissioning better. And I think the other one is David Nicholson used the phrase the tyranny of the political cycle. We need to get out of the constant thinking that structural reorganisation will provide a solution. And I think that's because it's the only thing, politicians know, it's the only thing that can be done in their short time span which will give the illusion of action.
I'm still trying to get to the pivot for change in this, because as soon as you talk about sharing information, I know what they're thinking. $1 billion on a personally controlled electronic health record in Australia, and we're still not there, and we're a million miles away, versus systems like in the Northern Territory where they've got a shared electronic health record. Some Medicare locals in this room are moving towards that independent of the Commonwealth system because there's goodwill. The shift in incentives where I'm incentivized as a general practitioner to say I actually no longer own the health record regardless of what a High Court decision has decided.
So there's the what's in it for me is a really important question for professionals. And the illustration from that for me came when I went to the VA recently, and I spoke to the clinicians about what difference had it made that patients had their own records and could secure message. Their clinicians could use much more electronic communication approaches. And they told me that counterintuitively it had two impacts for them, which they found beneficial, and they'd initially been resistant to the idea. The first was that they knew their patients better, and the second was that they saw them less frequently. So they had more time with people when they were with them. And I think there's something about when I went to Amir Hanan's practice in Manchester and met with his patient group. He's actually just published in the Integrated Care Journal the evidence from his work of 20% of his patients now have access to their own health records. And for that cohort of patients, they see them less frequently. But they're also utilising other healthcare resources less frequently. And he reckons the tipping point is about 50% of patients having access. But he's created that. There's now a pull from clinicians and from patients because they've seen what the experience means. I think the final thing is it will be, some of it will be about money.
Yeah, the first CEO of the Illawarra Area Health Service was Peter Brennan, and in 1986 he amalgamated the 9 hospital medical record departments and introduced a region-wide medical record with a system called DocMail. And every baby born in the Illawarra since 1986 has had a unique record opened on them, and one record follows around everywhere except GPs. And what's really interesting about that is that everybody in the Illawarra assumes that that's how it works in the rest of the country, so they never talk about it. The idea that they can actually track what hospitals I've been to in the last 30 years and when I've turned up in ED and if I went to the sexual health clinic or whatever, because it's actually all in one record. And nobody in the Illawarra thinks that's unusual. We just accept that that's how it should be. And nobody's really worried about the fact that the GPs are not part of that for 30 years. The GPs know that record. And in fact, there is a system called DocMail that notifies GPs that you've gone to hospital, and each time you move wards and each time you get a new diagnostic test, that goes to the GPs as well. And we take those things for granted, and then we say, okay, what next? So we have to be really careful that the transactional isn't the solution. I mean, I talked about get rid of structure. At the state level, you've got policy and funding levers, and at the local level, you've got transactional things you can do and cultural things you can do. And culture does eat transactions all the time, but we need to do both.
I want to talk to you, Martin, about this concept of complex care practices. So does that not potentially increase fragmentation? You've got another circle or square in the system? Because we have complex care practices in Australia we might choose 1,000 patients of high complex needs, intervene, and you do actually have measurable effects on demand. We're already doing that, but it creates if Bayside in Melbourne does it, and Royal Perth does it with specialised physicians. Some people do it with GPs, and you get potentially more fragmentation.
Well, it depends on your definition of fragmentation, whether it's from the system perspective or from the individual's perspective. So I was talking to a colleague in England about, well, how would we actually do this? And again, it was not, what I'm loath to do is dictate the solution from the centre, but rather highlight what the issue is, create a framework that enables people to create a solution, create the tools to create the solution, but then allow people to craft it locally. So I think there's 3 ways that it could be done. One is you could have standalone units, and some of those exist. 2 is you could have it within a federated group of practices, and we're now seeing the emergence of big federations in the UK, and I think there's a massive transformation going on under our noses, which is not driven by policy, but driven by the context in the UK. And the 3rd would be to have a hypothecated unit within a very large practice that would deliver it. When I've talked to, I met Aidan Halligan recently, and they've set up a number of homeless care and substance abuse practices which support people with who are homeless or have substance, who turn up in hospital units. And they're finding that other practices are actually collaborating with them and pointing, because they know that they don't have the concentration of skills or patients that develop the skills, and are asking the other practices to take them on, but working collaboratively with them. So I think it does create new components in the system. I'm not sure I would call that fragmentation. The other thing is the extensivist model in the States. It's a capitated budget for those patients, so it comes back to the funding model again. What's in it for me? If I put my back into managing this complex group of patients, I can actually make it sustainable because I can redeploy the resources to good effect. It's a really interesting perception, and perhaps the easiest way to reframe it is to compare the costs prior to these reforms. And I think it's either the Nuffield Trust, it might have been the Confederation, published data on the relative management costs of the NHS compared with the private sector. And we would look pathetic compared with the management costs in the private sector for what we're trying to do. So I think that's a myth. The second thing is we've cut the management costs by 50% since then, which is why I'm completely knackered. So we've had half, as a clinician, emerging from the programming which we go through, extensive programming, better than Scientology, that we go through in medical school. I've been deprogrammed over the last 10 years to realise that I value management. There's a synergy between good clinical leadership and good management, which is incredibly powerful in delivering high quality care. And I get frustrated by people who say that management bad, clinical good, or whatever. That's complete tosh. We need both and also the perception that there were high management costs in the NHS was tosh as well.
So it's a brave decision to transfer $5 billion to social care, and I'm thinking of what companies say about their advertising budget. I know that the money I spend in advertising works. I don't know just which bit of that money is working. What are you actually going to spend that money on? What do you know in social care that's going to make a difference? Because you could just be throwing good money after bad. There's probably less evidence in social care than there is in the healthcare system. Yeah,
so Minister, that's a courageous decision. Yes. To take an aphorism from one of your earlier allusions, you might well say that I couldn't possibly comment. The issue, I think, is I think it's quite scary. However, this is not based on evidence, but it's more on hope. One of the great examples given in the UK is Torbay. And why is Torbay? Why do people go and look at Torbay? Because they decided to pool social care and healthcare resources I think about a decade ago. And they are getting better healthcare utilisation, better outcomes than comparable areas in the country. And so people have researched it. Now I think it's that triumvirate of leadership, money, and information.
So, but let's just dig down a little bit, because you're talking about good integration is local, and you're both talking about that. I mean, how local? I mean, the concept behind the National Disability Insurance Scheme, in theory, is that you pull exactly what you need as an individual from the system, from, if you like, a notional budget, whether in fact that's what happens. So is the social, and so the risk is that even at a local level, you prescribe the social care. Are they, when it's working, are you genuinely getting the consumer pulling the care that they need or that somebody else thinks they need?
Okay, well I think the first point about alignment, if you look at where the decisions about social care are made, they're made at the local government level. So we probably need alignment, and that's where health and wellbeing boards sit. Our problem is I think we've got a number of small health, we can have, so for instance where I've just left, Lincolnshire, there are 4 clinical commissioning groups. So I think that actually does introduce a level of complexity which is...
so how do you pull it down to the maximally local level, which is to the level of the individual and their family and the carers?
So what we're just introducing this year in the NHS is personal health budgets for complex healthcare budgets. So we are looking to align the health and social care budget and say that's a sum of money, how would you want to use it, and move away from the rigid control. I think there's some severe risks around that, which are around how far can you go before you lose the risk pool and manage the risk that we've got when you've got a capped budget. Does that help?
Maybe, we'll see.
I think it's a $64 question, which hopefully will be $63 of it will get spent.
I might just talk about how the NDIS is working. The NDIS is working that people get assessed. This is people who have got severe disabilities in the main. People get assessed and get allocated somebody who's called a planner, and that we would call a case manager or a care coordinator. People get allocated a sum of money. On average at the moment it's $45,000. The maximum package at the moment is $50,000. And the planner works with that person to agree on the package of care they're going to receive. So it is coordinated care, and the planner is, in a sense, the commissioner. The language around that, the new jargon word is CDC, consumer-directed care. It's now the official policy for aged care as well, and it's the same in NDIS, that people get choice.
But
the real questions whether it's about what people want or what they need, and what the benefit, whether people can make informed choices about what's actually going to be the most effective way to spend that money.
But somebody designs the menu. So you've got to spend the money, you're buying stuff off the menu.
Yeah.
So the menu still describes what the person can get.
Absolutely, and the other side of that is that there is a very naive assumption in the NDIS that all the services currently on offer are going to be there. But in fact, all of the money is agencies are no longer going to be block funded. They're going to have no funding, and the small ones will all fall apart because they won't have the money to keep going once the NDIS is up and running, and they're depending on individual consumers coming to buy from them.
Martin?
Yeah, so just to point out that as of next week, there will be an incentive across England for every general practice to risk stratify their population, to identify the top 2% in that risk stratification process, to ensure that every single one of those patients has a care plan and that they have a named accountable GP. And it's the first, you talked about moving at scale and pace. Given the level of incentive, there's other monies which has been put in we've shifted money from QOF to supporting general practice.
And what happens next? So once they've done that, what happens next, and how are you going to evaluate it?
Well, the simple answer is whether the system remains sustainable, because what's breaking the bank is our admissions to hospital. I think it is about trying to align to the values and purpose that practices have. I think this is about skin in the game. Yeah, the reason I got into management was when fund holding was introduced in the early 90s. And I could see that by changing my behaviour, I could release resources which would allow me to deliver. I could impact. So prior to fund holding, I couldn't get an X-ray for a week. Blood results would take a week to come back. We had no control over the way hospitals operated, the information they gave us, and by shifting the locus of influence to the money, that created a big change. Now there were problems with that, and I think the biggest problem was it was only 15% of the budget, and it was down to individual practices, which was never the original intention behind fund holding. I think we're back kind of in that territory again, where practices can see the skin in the game, but it also goes back to my gearing in the system. We do have a cap fund, so people realise that if they don't get involved, eventually they will atrophy. They will, the evolution of the system will mean they'll be made extinct. So
is this an accountable care organisation by another name?
I think not yet. But I think there is an element that we're starting to see that people are really thinking about this, that we need to have system management, and that means that somewhere along the line somebody needs to be accountable. Now whether that's the general practice or whether that's another organisation, my personal view, my personal bias is if you don't start right at the roots.
But actually what I was driving at, because I thought you were driving at, is that the only people who really carry risk in the system at the moment are the patient, the hospital, and the funder.
Yeah.
And the doctor and clinicians don't carry risk. And one of the features of accountable care organisations is that clinicians do carry financial risk as well, but also the potential to gain.
Yeah.
And is that in your head there?
Yeah, I think that's where the compass is pointing, but also that we need to get the governance of that right, so that it's about not just about cost, it is also about quality, because otherwise you end up with a mid-Staffordshire. I think self-managed care, actually, that's why I always say self-managed is not abandoned care. And I think it is about, I know, and that's why I think it's a bad term. I think it is about giving people as much control as they want. And this goes back to the original work by on patient understanding the level. Again, it's not a great term, but the level of patient activation. So the example, I don't think we have a profession which is universally trained to approach this in the right way. So that's one of the big cultural changes, is training and approach among professionals to this. I think we don't yet have the right incentives and levers in the system to support it, so it becomes sustainable and people see the benefit of doing it. And I think we're rediscovering, without going back to a sort of Hovis era, we're rediscovering the importance of relational continuity. Although interestingly, other research has shown that people will sacrifice relational continuity for access. So if you're told you can see the doctor, but you're going to have to wait a week, 10 days or whatever, there's a limit to the elasticity that people will give to relational continuity. So I think they're really great questions, and I think it is about integrated care having that relational element.
I'll come to you in a second, Kathy. I just want to ask a question based on that. So that's already happening in Australia. There are a lot of people who don't identify having their own general practitioner, but those who do, if they think it's something minor, they'll go down to what we call the bulk billing clinic, corporate clinic down the road for the quick and dirty, and then when it's something serious requiring intent, they'll go to their GP. The extent to which it is worth investing in the medical home, to use the American term because they've reinvented what we've known for years, in this frame.
So
and then what the medical home has to do to actually truly be the medical home.
Yeah, so I think what we need to demonstrate, and this is where the power of information is, I think of it as this in physiological terms. The reason my level of thyroxine is right in my blood, or I hope it's right in my bloodstream at the moment, is because there's a feedback loop. So the thyroid gland monitors and the hypothalamus monitors, the pituitary gland monitors the levels of thyroxine in the blood.
For a surgeon,
But-
very impressive.
But we and for a GP as well. But what we don't do is we don't feed back. We need at that level of feedback with people, both the professionals and people, to see what is the value. And that's what it comes back to this. We don't measure nothing happening. I mean, it stunned me recently when I realised that we'd reduced cardiovascular mortality over the last decade by 40%. It took the Global Burden of Disease study and a sub-analysis of that to show that in terms of diabetes outcomes, the UK leads Europe. But we tend to just track activity and what goes wrong, and we don't monitor and feedback what the benefits of this investment bring to you in terms of your health and care, but also in terms of your professional working life. I think it's, this is all part of the shift that we need to make.
Kathy, and then Dan.
Yeah, I want to go back to one of the slides I put up, and I said that I thought there were three groups of people. There were self-navigators, and there's nothing in it for them. There's the people who need and could benefit and want guided navigation, and there's actually a third cohort who really need very active management. And I think if we can start to give people help people make choices about what they want. And I recall a very good program at Capital Coast in New Zealand for patients with chronic mental health conditions who was asking if they'd like to be linked up with a GP who would actively be involved in their care. And they're saying to the GP, apart from the fact that you can click-clack them, we'll give you $500 a year for active case management. If the person doesn't turn up, you ring up and find out why, or you ring them the day before and you remind them, and we understand that sometimes they won't turn up, so here's a $500 capitation payment in conjunction with fee for service to agree with each person what's going to be the best way for them to be able to tell you how they're travelling. Really simple model that achieves really remarkable things. It doesn't have to be big and complex. In answer to the question that Lewis had of how do you do it, I think this is where the MLs have got potential to be really helpful. I think it's going to have to be bottom up. It's going to have to be a region that gets together and says, we've got 30 doctors in our town who are prepared to test blended payment models. We're in it together. And this is how we want to change things on the ground. I don't think top-down is going to work, particularly in the light of the current configuration of politics around the country, but some bottom-up, and it has to be, I made a joke before about pilotitis, there has to be a sufficient dose effect at the structural level you can see a difference. One or two people doing it won't make a difference. We have to have a sufficient dose of it that it's not just a pilot, it's a different way of doing. You probably only need 3 regions.
We've got 5 pilot areas at the moment running on testing patient activation measurement and how that can be used by clinicians to influence their approach with patients.
What does it mean, patient activation?
It's this determination of how much. Where's my locus of control? So I'll give you an example. I saw when I was first implementing choice in our hospital services, I saw 3 patients in a row who I offered choice to. The first one said, I had to offer them 5 options. The first one said, that's really interesting. I'm going to take all that information away, read up on it, and I'll make a decision about where I want to go. The second one said, that's really interesting. I work in Rotherham. It would be really convenient to me to go to Rotherham Hospital. I'd never referred anyone to Rotherham Hospital in the previous 10 years. The third patient looked at me and said, don't be silly, Dr. McShane, tell me what to do. And it's understanding the person in front of you and not assuming, not making assumptions about what they want, but actually trying to understand what level of ownership they wish to have of their own healthcare.